afternoon, everybody. Honorable Chairperson and learned audience. Well, mine is a short study, implantation of permanent pacemaker in COVID-19 co-infections, statistics for management at dedicated cardiac hospital in Bangladesh. Well, in initial days of COVID-19 in Bangladesh, there was a generalized havoc among the community and also among the physician, what to do with the patients and what is the problem with us. So, so in our hospital, we deferred the electric cases, only the emergency cases were done. But in case of high-grade AP block and sinus node disease, that is a permanent, that is a fundamental concern for us. We cannot defer these cases, we have to do this. How should we proceed to do this case is the main concern of my study. And as we know, high-grade AP block and sinus node dysfunction are most common indication for permanent pacemaker, and conventionally stated patients with high degree AP block have notably poor survival rate. And in the era of COVID-19, management of heart disease patients with concomitant virus infection has not been completely defined. Moreover, the hypothesis that COVID-19 could lead to exacerbation of conduction system disorders or sinus disease or new onset high degree AP block is actually under study. Surprisingly, only few cases have been described. In this study, we are mainly concerned with the patients requiring permanent pacemaker with concomitant COVID-19 infections. Methods in this study was done from early part of the March 2020 to the September 2020. During this period, 98 cases of permanent pacemaker implanted in our hospital. Among these 98 patients, 12 were COVID positives. As per our hospital protocol, after admission, all patients underwent to TPM with proper protection and PPE. And after TPM, they were housed in a isolated COVID unit. And when the COVID reports come back, we installed pacemaker those who are COVID negative. But in case of positive patients, we sent them to COVID unit and treated accordingly. And after the COVID result become negative, we again place them for treatment. The results are basically very simple. As my number of study is very small, the most cases are with complete heart block, and one patient was with end of life. And age of the patients, as I mentioned above, mostly elderly group of patients are there. It is 68.3. If you consider the heart rate and other things, it is within a normal limit. And the most common symptom among the COVID patients were fever, cough, and in some cases they reported nausea. Only one patient need high flow oxygen during this hospitalization period. And for COVID-19, we have implanted TPM, and the patients were TPM independent. And during this period, the longest patient who was under TPM was 30 days. And the average duration of TPM was 21.2 days, and time to become the RT-PCR negative was 20 days. And the type of pacemaker used in 75% DDI, DDD, and VVIR in 25% cases. So let's go back to discussion. The patients with cardiovascular disease with associated COVID-19 infection are at a high risk of mortality, and treatments of this group of patients are demanding. The European Society of Cardiology guidance and Italian position paper, I cannot remember the name of the Italian society, position paper about the treatment of cardiovascular disease in COVID-19 infection patients have been published. The suggested management of antiventricular and sinus node conduction disorder patient is not similar between these two groups. They have some fundamental differences. Let's see what the difference is. On the left side of the panel, there is the European Society of Cardiology report. In this case, persistent symptomatic bradycardia due to AP block and recurrent sinus node dysfunction, they recommended all medication causing bradycardia should be stopped. Isoprenaline, atroprenaline should be administered. And this is their mainstay of treatment. Temporary pacemaker may be considered. After recovery from the COVID-19 infection, need for permanent pacemaker implantation should be reassessed. And if needed, it should be implanted. Where is the Italian position paper? They say the placement of TPM should be avoided, favoring the pharmacological management, and external transthoracic pacing and in sedated patients should be tried. Early implementation of permanent pacemaker device is the presence of low probability for spontaneous recovery is the mainstay of their treatment strategy. Extremely necessary cases, if TPM is needed, then balloon electrode should be used. The use of intradermal sutures with fully resorbable sutures is preferable. Removal of sutures or staples where it is used should be delayed, and it should be removed after 15 days. Apart from these two guidance, we have some papers, basically case reports. One such case report, this is the first case report reported in the early part of 2020. In that case, Riveti et al. Reported the first case of COVID-19 infection patient with symptoms of AV block, treated with early PPM implantation. In their opinion, this approach allowed them to preserve all the medical equipments and other patients from the potential viral contagion of non-COVID hospital, and the best outcome for the patient by transferring the patient after doing the PPM to a COVID-19 facility. But in other case from Europe, Igan Tuk B et al. In March 20 reported a case about a 78-year-old man with second-degree 2:1 ventricular block and ventricular rate of 46 beats per minute with COVID-19 pneumonia. The patient was treated by conventional management and isoprene. 3 weeks after the admission, when the clinical picture substantially improved, permanent pacemaker was implanted. So they don't use any pacemaker. But our approach was conventional and simple. All patients admitted for PPM initially, TPM was done, and they were housed in the dedicated COVID isolation ward. RT-PCR negative cases went for PPM, and positive cases are treated till they were RT-positive negative. After recovery from COVID, if they were febrile, PPM was done at the earliest convenience. Our approach is supported by the consensus to prevent cardiac implantable electronic device in infection. It is recommended generally to wait for 24 hours since then febrile patient becomes afebrile, especially in viral disease, as these group patients are seldom associated with infection. And in conclusion, maybe my sample size is small, but this protocol that we followed, although total sample number is undersized, but can pave way for better patient care for the future. Thank you very much.